Changa chitab kalenjin ako itagat in tetutetab Health Watch. Embe tutab raini kikwenye gamutik chetinyege ak sigisiet.
Fertility or reproduction involves both men and women. It's like a dance. It takes two to tango. So both systems must be working very well. Here today we are going to look at the female fertility system. We have a model here. Now the basic part of fertility is the uterus. That's the house where the baby grows, and part of it in the fallopian tubes is where fertilization occurs. So we have the uterus here, we have the birth canal here, we have the ovaries here, and the model shows some eggs that are growing as part of the cycle, and the very important part, the fallopian tube. Okay, so usually the egg during fertilization will come out and get into the tube and go up, and somewhere in the middle of the tube it will meet the sperm that has been deposited and has come up, swum up, and the fertilization occurs here. And once the embryo grows, by around the 5th and the 6th day after fertilization is when the embryo comes back to the uterus and implants in the uterus. So in short, the fallopian tube is almost like our laboratory. That's where all the work happens. And that's why it is very critical that the tubes are working properly.
Kaimutikab sigisiet kotinye kwonyik ak muren, ak kaimutionito koibu tuguk cheterter.
I'm going to talk about the causes of infertility. So infertility, as I said, can be contributed to by both men and women, and sometimes both. For a fact, we know that in our population here, and even the world over, 10 to 15% of all couples will have a problem or suffer infertility. In fact, when I sit in my clinic, out of every 10 patients, 5 could have a problem with conceiving. And we say that a couple is having an infertility problem when they've been trying to get a baby for at least 12 months and have not been successful while meeting at a regular, at frequent times, at least 3 to 4 times per week. Then if over a year they have not managed to get pregnant, then we say that they have infertility. For a fact, we know that a third of the causes of infertility are contributed to, it's a woman who might have a problem. Another third is a man. You know, in the African setup, we think that it's only the woman who could have a problem. But more and more, we are seeing many more men who have problems that could contribute to infertility, and it's good that we address them. Then in another 30%, you find the woman has a problem, a small problem, the man has a small problem. And both of them, if corrected, could treat the fertility problem. Then another 10%, we call it unexplained infertility. We can't tell exactly who has a problem, but there's a problem. So we are not able to list the causes. So when it comes to women, we'll think about 3 aspects. The first is the housing and the uterus. Okay? The uterus and the tubes can be a cause. So majorly we live in what is called the infertility belt, south of the Sahara, where there's a lot of tubal blockage. And this has to do a lot with mainly infections that are not treated well. So the biggest cause of infertility is when there's blockage on this tube, okay, on the fallopian tubes. It can be either one or both, but in most cases for it to cause infertility, then both tubes are blocked. And they can be blocked here, they can be blocked in the middle, and they can be blocked at the end, which we call hydrosappings, which is a very common cause, especially when we have infections. What causes tubal blockage? It can be infections, because one of the things that happens is that our population, people get infections, and instead of going for proper treatment, they self-medicate. Okay, so you have incomplete treatment of infections. So you find that that could infect the tube, cause a lot of scarring, and that causes blockage. There are other medical conditions that can cause blockage of the tubes. Majorly, a condition called endometriosis. Endometriosis has become more common Either because of it is not exactly known, but it's postulated it's the way we live. There are a lot of hormone modifiers in our environment and in our crops, which makes the lining of the uterus, okay, which ideally should be shed downwards, it comes backwards and starts causing inflammation outside the body, okay? What allows that is what we don't know. And it has especially become more common. People are more aware because of societies. There's some media personalities who have been afflicted with endometriosis. So at least more people know that that can be a cause of infertility. Another cause is when the uterus itself is affected. Things like fibroids. When there's a fibroid, which is an abnormal growth of the muscle and the fiber in it, when we have a fibroid inside the uterus, it is a common inside the uterus can cause infertility. Other conditions inside the uterus, like polyps, that's another abnormality, and scarring. When people have had, especially recurrent pregnancy losses, and they have had a lot of cleaning, or they've had infections, things like TB, can also cause scarring of inside the uterus, so that this cavity, instead of being open, it becomes closed and there's nowhere for the embryo to grow. That is a condition we call Asherman's, and it's becoming really common, and that contributes to infertility. Then after that, in women, the problems of the eggs not coming out, okay? A condition we call anovulation, ovulation disorders. Now, the commonest cause of ovulation disorders right now in our population, for the younger population, is a condition we call polycystic ovarian disease, which, like endometriosis, has become more and more common because of our lifestyles. We are becoming more obese. We are eating foods with lots of toxins, which become hormone modifiers. So we get polycystic ovarian disease, which is a disorder in which women get a lot of facial hair. They have much higher testosterone than they should have. Facial hair, acne, they become obese, and then we find that their periods are skipping. Okay, instead of getting a period every month, we find a woman can get a period after 2 months, after 6 months. Some women don't get periods for 3 years, and this starts usually at a very early stage when they're in high school and such. So it's a very common problem, and more people are becoming aware of it. Another very important cause of anovulation is other hormonal disorders. When any other gland is not working correctly, like the thyroid, or when we have the milk hormone prolactin, which is usually produced in the brain, that also causes problems with ovulation, and we say that people have hormonal disorders. And last but not least, and very important, is age. Age is quickly catching on as a reason for infertility. Why is that? As women get more educated, join the workforce, you find that now we no longer are getting children in our 20s, and people are waiting until 40 to start trying to get a child. And remember, that phenomenon of the biological clock is actually quite real, because as we grow older, the number of eggs and the quality of the eggs reduce. So that by the time you're trying to conceive at the age of 40, you have 5% chance of being successful, while if you are in your 20s, the chances were between 30 and 40%. So you find that age is really contributing a lot to infertility.
Kaimutik chuton e muren missing kotinyege ak genetic factors koboto amitwogik cheome.
About 30% of cases of infertility are caused is a man who has a problem. And how does this happen? Usually we know that the man has a problem when we look at the semen, we do a semen test, and we find that there's a reduced number of sperm. They could be reduced. Usually the normal count is about 15 million and above per ml. You can imagine how many sperm are produced in very little quantities. So you find maybe someone has 1 million sperm per ml. That affects fertility a lot. Or they could be a normal number of sperm, but their speed of being able to move within the genital tract, because we said that the sperm must be able to move all the way from down, from the cervix area, and get itself to the tube. According to me, that is like a 42-kilometer marathon. So you're competing, and if you're not able to, the egg will have gone by the time you get there. So the sperm has to be very fit. It has to be moving at a particular speed and being able to move forward. So if there's a problem with that, it causes a problem. The other problem is if, because of some problem like a genetic abnormality, you find the shape of the head is not good or the tail is abnormal. So you find some, instead of having a spearhead shape, which allows them to swim like a fish, they are round. Or they have two heads, or they have two tails, or they don't have a neck piece. So all those are what we call morphology problems. Morphology is a scientific name that means shape. Okay, so when there's a shape problem, also it affects the way the sperm works and how it fertilizes the egg. So what are some of the reasons why this happens? I've already mentioned one, genetic problem. Some people are born with that problem and they will never have good sperm. Others, it's the environment. Okay, environment affects sperm a lot. One is working in very hot environments. People who work in hot furnaces, maybe they're in industries, or they're working in as chefs, then they're working in a very hot room. Or men who like, which is very unlikely in our population, taking very hot baths and for very long, wearing very tight dressings and undergarments. If already there's a problem, that wasn't it. Or people who work with hot devices like it's been proven that having laptops and placing them, because especially the older laptops, now they are better, they are slimmer, but the older ones used to affect, they're producing a lot of heat in the lap region. Another cause is chemicals. People who work with farm inputs, a lot of chemicals tend to affect a lot of the pesticides, herbicides that we're using, especially if you're not well protected. You must wear a mask. You must not handle the chemicals with your hands. You wear gloves and you use something to stir, not mixing with your hands. That could affect. The other thing is very common in our population, drinking and smoking. Smoking is extremely damaging to sperm. So you find that it affects, especially if someone already has a small problem, if they then add smoking and drinking, then they tend to have a worse problem. And the other thing is lifestyle diseases. Very obese men might have hormonal disorders. So that generally, those are the commonest causes, but there are many others.
Chigilisetab sigisiet ko eng ngamutik chenotin ko gynecologist ako umang walutik choton eng kasarta nenwach.
The test for infertility, we'll start with the male partner because that's the easiest. Even when a couple comes in, we test the male partner first because it's the easiest to roll out. And the test that we do is called a semen analysis. Okay? And medically we say semen analysis, but it means a semen analysis. We are getting the sperm, putting it under a microscope, and very easily within 10-20 minutes you have the report of the number of sperm, the speed of the sperm, and whether they have normal shapes, and whether there's any other infection. The other thing that is coming out a lot is a lot of pus cells in the sperm. With that, you're also not able to be fertile and you need treatment. There's a male client who's told me that, why are you saying it's easy? Producing sperm in a clinic is not easy, but it's not easy, we recognize. But it's much easier than a lot of the other tests that would have to do. So it is time men embrace and say it is an easy test to do. So if we're having a problem, I'll volunteer and I will go and be checked first before my wife undergoes all these X-ray radiations, and yet I could have something that needs to be corrected. The other tests for men is especially those ones who could have hormonal disorders, and you're able to tell men with low libido, low energy levels, we need to do hormone tests. And the particular tests that we tend to check tend to be FSH, follicle stimulating hormone. We check the total testosterone hormone, and we also check the prolactin level and many other hormones, but those are the basic. So if we find a problem with any of them, we are able to correct. The other test that we do for men is if they could have a condition called varicocele, which apart from testing clinically, we need to confirm. Okay, they can have a hydrocele, it's a swelling in the testes, a varicocele. Varicoceles, because of the heat generated around the testicles, tends to reduce the sperm count. So that one needs to be diagnosed early, because if it's caught much earlier before the sperm is completely damaged, it can be stopped. And then some men have abnormal growths in the testes, some even cancerous. So when we find there's a problem with the sperm, we need to actually confirm that there's nothing else that is abnormal in the testicles for the sake of the man. Not only for fertility, you don't wait and then they have testicular cancer. Okay? So it is important that men volunteer to come with their wives, especially on the first or second visit, to be checked and not waiting until everything has been done and then now they are checked, because they could have a problem that needs correction.
Kosubkei ak Dr. Jane, komakigetyin testinoton en muren koboto kokeker muren chechang koyoe testinoton angekerchin ageny.
I will give kudos to the men. Men are improving and we are getting a lot more men. Before, it would take, a woman would come 10 times before the man ever agrees to come for a check. But now with a lot of the education, like this show you're doing, that is very educative to the men, I'm sure they're listening, they will know that 30%, up to about 50% of cases, they could be the cause, and most of these causes are correctable. Instead of waiting to have a homestead without children, and you could be the problem, then we need for the men to volunteer. I've had young men especially, I really like the newer generation. I've had a man who even before marriage says, I just came to check that I don't have a problem with fertility. Or they are married, they've stayed for 3 months. I came to check whether I have a fertility problem before even it starts stressing my wife. So Karen, our men are improving and they're going to improve. That's the only thing I can say about it. A lot of them are coming for tests, but we educate them, we tell their wives to give them the health message, and many of them agree to come if they have not been coming. You only need to come once. The rest of the time is to come and support your very stressed wife so that she doesn't have to come alone all the time. But if you come the first time, for most men, we have finished the investigations. Remember I said the test takes 20 minutes. Okay? So if you come, your sperm is normal, the speed is normal, everything looks normal, we now move to the woman. Okay? We'll not keep on telling you come, go, come, go. But if we find there's an abnormality now, depends on what other tests we need to do. Okay? It is like any other problem. It's dependent on the problem that you have that you're able to know what to do. Okay? But if there's no problem, we don't need to stop you from going to work. You just need to maybe support us with bus fare and money for the tests. Then the woman can be coming and you can bring her a few times.
Testien kwonyik kotiengei kaimutik chetinye icheget kou ole kamwa Dr. Jane.
For the women, the tests depend on the cause, but as a baseline, we want to confirm that the tubes are open. Okay, so one of the most important tests is a test where dye is pushed inside the uterus, and then we are able to visualize the tubes. It's a test called HSG. It's a type of X-ray. Very important, because if there's any blockage, we are able to see that the dye did not move to a particular point. Then we can do a pelvic ultrasound to check whether there are fibroids, whether there are polyps, okay, whether the ovaries look polycystic. So an ultrasound is a very important test. And then for those ones with abnormal menses, then we do hormonal tests to check whether they have thyroid problems, they have prolactin problems, whether they have polycystic ovarian disease. Apart from the scan, we are able to do some hormone tests, things like fasting insulin levels and testosterone levels, to just know whether that could be contributing to the infertility. For some, we're not able to know exactly what is the problem because they are scarring outside the uterus. And we either do hysteroscopy, which is a type of operation, but it's like an endoscope. We go and look and get out, or we do laparoscopy, the keyhole surgery for diagnosing. That still falls under the realm of testing.
Kora, konyoisetab testi chuton ko terter kosubkei ak walutikab testi nekakeyai.
Treatment is very specific. We will talk about a treatment of infertility when specifically the male. So when we find that the man has a low sperm count or they have no sperm, you see, lack of sperm is also a real condition, very common, a condition we call azoospermia, meaning there's no sperm found at all in the semen. So the man will produce seminal fluid, but there's nothing moving inside, and such a man will not be able to fertilize, to make his wife pregnant unless there's an intervention. So the basic one for reduced sperm count and such is the one we've already talked about antioxidants. And usually, especially when it's just slightly reduced, we give antioxidant tablets. And usually the man has to take them for some time, up to about 3 months before we can get results. Because remember that the sperm being produced today by a man started being made 72 to 83 days ago. Okay? So you find that you need to have taken the antioxidants for some time to make a change. Okay? Then the other thing is, if the sperm count is low but not too low, but a sizable amount of quantity, then we can even give, we can do IUI. But before I go to IUI, some men have a problem with their hormones. And such men also tend to have what we call erectile dysfunction. So you find a man has a woman, but he's not able to please her. Even when he wants, he's not able to please her. That could be contributed to by hormonal issues. So for such men, we usually do, whenever we get that kind of history, and majority of the men who come with infertility, we will have done hormonal tests. And if we find some that are abnormal, we're able to correct them. If we find some hormones are deficient, we're able to give some injections to just boost the hormones, and the men can be able to produce more sperm. So this is a correctable condition, especially a condition we call hypopituitary hypogonadism, hypo. So for such, you're able to give injections, and the men are able to produce sperm. The other condition, so if we find that the sperm is low but not too low, then we can do intrauterine insemination. Intrauterine insemination is close to artificial insemination that is done for animals, but in this case, at AI for animals, the sperm is deposited in the birth canal. But intrauterine insemination, we prepare the sperm and we introduce it inside the uterus using a soft catheter. Okay? So this one improves, even when you have a very small quantity, we are able to improve what is available to the tubes because we have concentrated it and put it right near the tubes. Another place where we use intrauterine insemination is for men who do not have any sperm, and you are doing a sperm donor treatment. So of course, we only go to the sperm bank and the sperm is prepared. It is then deposited inside the uterus to facilitate fertilization for this couple. Then for those with extremely low sperm counts, then we do IVF, in vitro fertilization, where the egg will have been collected. Each individual sperm is put inside the egg to facilitate fertilization, and then the embryo is put back in the uterus. There are some men who have sperm inside the testes, but because of blockage of the tubes that take sperm to the outside, like the vas deferens or the epididymis, then we are not able to get sperm coming out. So for such men, we are able to surgically retrieve the sperm from the testes. So under some local anesthesia or general anesthesia, we are able to put something to aspirate the sperm from the testes. And one such procedure is called TESA, testicular sperm extraction, which is a surgical technique to be able to get sperm from men who do not have sperm. So for women, it's a bit more complex and we have to treat the condition. We said one of the commonest conditions is fallopian tube blockage. And fallopian tube blockage, unfortunately, very few of them can be corrected because unlike what I'm showing in this diagram, the tubes are very narrow and a lot of them cannot be corrected surgically. So when the few that can be corrected is where the tube is blocked at the extreme end, a condition, and it has to be very mild, hydrosalpinx, as a condition called hydrosalpinx, where there's a swelling of the tube. So this can be opened, but very rarely is it successful. We have success rates of less than 6%. So for now, when people have tubal blockage, we advise that they go for IVF, in vitro fertilization, to be able to bypass this. Then the other conditions involve the uterus. If people have fibroids or they have polyps, we advise that they are operated. They can be either laparoscopic operation or open surgery, and we remove the fibroids and correct the condition. But if they have a blockage of the lining, the condition are called Asherman's, then we need what is called hysteroscopic surgery to go and remove the scars that are inside. And that has allowed quite a number of couples to have families. Okay? Then the biggest problem after the blocked tubes is ovulation disorders. So for such, if say a client has polycystic ovarian disease and they're not able to ovulate an egg every month, then we have to aid in ovulation. So the first treatment that we do is something called ovulation induction. And ovulation induction, we mainly use tablets, okay? So we give tablets for a number of days in a month, and we hope that by the time of ovulation, they'll be able to give an egg or 2 eggs. So apart from the tablets, if the tablets are not working, then we can give injections, which tend to be given for some time of the month, for about 10 to 12 days in the month, and that will aid in ovulation induction. It will help in facilitating ovulation. Or if it's any other hormonal condition, we can give medication to treat the hormonal condition. Like say, if it's a thyroid problem, we can correct the thyroid disease by giving thyroid supplements. If it is a prolactin problem, the one for the breast hormone, then we can give tablets to reduce that hormone and allow ovulation. And then when that fails, or when after we've corrected that, we then move either to intrauterine insemination that I'd already talked about, or we move to in vitro fertilization, which is IVF.
Eng kanyaisoniton bo kaimutikab sigisiet, kokamwa Dr. Jane kole bo kamanut amitwogik missing en muren.
Nutrition is important because we need a lot of antioxidants. These modern diets we are having of very reduced vegetables and fruits then cause a big problem, because especially in sperm production, there are a lot of what we call reactive oxygen species that can be produced during the productive process. And if you don't have antioxidants, then to neutralize, then it affects the way the sperm is, and you might find they have abnormal movements or shapes. And we usually treat by giving antioxidants, but the best antioxidants are the ones we get from our fruits, our red, yellow, green fruits and vegetables, and then eating a balanced diet that is with less sugar and less fat.
Ongetuen e wiki nenyone asikeng'alalen tetutietab IVF.